as we thank Dana and allow her to move on with her day, it's very exciting for me to introduce our next moderator, Joe Mullins. Anybody who knows the world of orthopedics and has a social media account probably knows who Joe is. Like we did with Dana, I'll let him give you a little bit of insight in, but even as exciting as having Joe here is the incredible panel that he's put together for our next discussion on the role of technology and the role of ASCs in healthcare in general. We're joined by just an absolutely spectacular panel, and I'll allow Joe to introduce them as he gets started. So again, thank you to all of our panelists. Thank you to Joe, and I'm really looking forward to this.
Well, Michael, thanks so much. So far, it's been interesting. I always love to open up my breakfast with Stefan doing a total knee. It's always an enjoyable way to get rolling. I've seen them live at Innovate, and you pointed out what a magical facility. He's really set a model and a standard for a model that the industry should take note of and is starting to. I've been in the medtech industry for 32 years. Just a quick background on me. Have been party to building a large number of emerging tech, medtech companies, especially in robotics, orthopedics, digital surgery, et cetera. And have been an active member in these switching, changing centers of care and what it's going to mean to the industry, especially from the OEM side. And since my relationship with Stefan started a few years ago, I've taken a keen interest in the payers, providers, private equity organizations that are now starting to really expand the capabilities here in the marketplace. Joining me today are Michael Ast, of course, Sharon McClure, from Blue Cross Blue Shield, Vaughn Bonney from Corin, Nitin Goyal Zimmer, Chief Innovation, and Caitlin Zula with SCA Health. So panel, thanks so much for joining. I want to start out with a couple quick slides that will set the tone for this session. And they're a little tough to see. I don't know if, George, is there any way to make those full screen? Because I had a problem. These 60-year-old eyes just aren't able to lock down on that. But that first slide basically is a slide. There you go. It shows some comparators, some really interesting comparators from January 2000 to June 2022. And your overall inflation rate is 74.4% over that 22-year period. But you can see holding the mantle for the highest rate of increase relative to other meaningful components in our lives is hospital services. Has been more than a 200% gain in cost, and not necessarily affordable. So that's a really interesting stat. Next slide. These are all wrap up into together. The next one is healthcare spending as a percentage of GDP over a similar period. It's now about 19% of our GDP and growing. And in comparison to other advanced countries, we are substantially higher from a GDP as a percentage of GDP in our spending. Next slide. Now, with that performance compared to spending, you can see the spending up incredibly high, yet lower healthcare system performance compared to the same cohort. And then next slide. And then the affordability against the same cohort. We are lower performing and we are the most expensive as it is to the affordability function. So I just wanted to use that as a backdrop to today's session with our panel. And I'm excited. You can pull those off now, George. Thanks. I'm excited with our panel. We've got payers, we've got providers, we've got clinicians, and I want to explore and throw out to the panel, are there really aligned interest of incentives across the board for our healthcare system? And going back to this is focused on the ASCs. The numbers I pulled recently, in 2022, there were 183 new ASCs. And another interesting stat, private equity now owns 130 rural hospitals in our country. And I maybe would not call those tier 1 or tier 2 hospitals, but certainly tier 1 is where most of our technology exists when we talk about robotics. Tier 2 and tier 3 are left off. So I want that as our backdrop for our session today. And Stefan, I would ask you for your input at this point in time on those subjects.
Yeah, those slides are a telltale sign of where our healthcare is going. And when we developed Innovate Surgical or the Innovate family, it was really focused on that premise that this is an unsustainable model. What I'm so excited about in this panel is that we have the stakeholders that can be part of the solution and want to be part of the solution. My relationship with Blue Cross Blue Shield, my relationship with SCA has been such a positive one, where they see the personal gain of the company is less important than trying to build a better mousetrap to sustain this, to reverse this unsustainable model. And so I'd love to hand it over to Caitlin and see what your thoughts is on what you think this trend is. You guys were in the management of facilities, and now you're part of a big conglomerate. And I know you guys have had some growing pains, and so I'd love to get your input, and then maybe have Shara also give her input, and then maybe focus on a little bit what technology will play.
Sure. Thank you so much, Dr. Kreutzer. Again, Caitlin Zula from SCA Health. I completely agree with Dr. Kreutzer and Joe's introductory comments. Incentives are absolutely not in line when you think about the primary driver of our current healthcare system, and that's all about fee-for-service. And fee-for-service, at the end of the day, incentivize volume and rate maximization. And that is why we are so passionate about finding ways to move more towards value-based care, which incentivizes all the things that we were lowest on in those graphs: quality, cost, and incredibly important patient experience. As Dr. Kreutzer mentioned, we are very much, as part of Optum Health, building a next-gen healthcare ecosystem that is all about providing true strategic partnership to physicians. We want to enable them to remain clinically independent and, of course, aligned around connectivity and quality and value and practicing evidence-based medicine. And we believe that the ASC model is quintessential value-based care, right? It's lower cost, it's higher quality. Physicians are incentivized to provide care at the right value-oriented site of service. Patients have an amazing experience. And we like to hope that partnership with the management team like SCA Health helps our physicians focus on what they are uniquely able to do, what they went to medical school to do, and that's heal. And then we are taking that partnership DNA that we've been known for in the ASCs and very much moving into the specialty practice space to do the same thing for medical groups and ancillaries. It's a big part of why I'm passionate about being part of the Optum ecosystem. It's all about using data and evidence to support decision-making, and at the end of the day, providing an alternative to higher cost settings that are usually driven when physicians and specialists are employed by hospitals or purchased by private equity. It's all about putting the physicians at the center of the strategy to improve healthcare in America.
Caitlin, I've got a question for you on that. So we've got the big OEM, the manufacturers who bring us the technology. We've got big pharma. We've got big hospital systems, and we've got big insurance systems. And it seems like the competition is becoming less and less as we start to have this, I would call it, enough roll-ups in those categories. So whenever you have a lack of competition, you also have a lack of driving costs down and driving quality up. So with that trend continuing, how do the dynamics, the thesis of competitive nature of the marketplace and the PE firms now getting a lion's share of the ASCs, and PE, God bless them, but I think they're more interested in profits than patient care.
So Joe, I think it very much depends on the reimbursement model that all of those participants that you listed are operating. If you're in a fee-for-service model, absolutely. More widgets equal more money. And again, why I'm so grateful to be part of Optum Health and our focus on risk-based lives, certainly in Medicare Advantage, what we've been known for, but moving very thoughtfully into commercial risk, is it's all about affordability. At the end of the day, you can't succeed in a risk-based arrangement if you're not focused on affordability and taking costs out of the system. We know that specialists drive over 50% of the healthcare spend, but yet their professional pro fees are only 7%. So it's not that the specialists themselves are driving up costs, but rather it's all the expensive ancillaries around it. And that's why, as we begin to think about how do we create a lower cost, high value healthcare ecosystem that has a lot more focus on obviously patient experience and quality, but also value, that you'll be able to reduce that cost trend.
Joe, I'd love to comment on that and follow Caitlin's comments there. Nathan Goyles, Zimmer Biomet. Just as a background, I'm a physician who have worn a few hats. Previously was at Optum and UHG a few years back, and now lead innovation at Zimmer Biomet. And Caitlin makes a good point as it relates to Optum. Interestingly, Optum's health incentives are probably the most aligned because they're vertically integrated. They're the insurer, the ASC, the provider in many cases. And so in their case, it actually works out quite well because although there may be lessening competition, it works that the payer, the provider, and the facility are all aligned together. So just kind of a unique model that is clearly what others are growing towards, as you heard Ms. Jacoby talk about Walgreens and CVS Health and Amazon and the roll-ups that are occurring. I am curious about how we think about value-based healthcare now, though, with BPCI, bundled payment care initiatives run by Medicare. Basically, the cost was driven down to the bottom. I mean, many practices, mine included, started out where we had already had the efficiency, so there was no opportunity for driving the cost down further. I mean, our discharge to a care facility, like an acute care facility after the hospital, was less than 5%. And so, whereas some practices were starting out with a 90+% discharge to acute care facility. So in the setting of, let's say, total joint replacement today, you can imagine, I'm sure Dr. Kreutzer's facility is extremely efficient in the way that they manage and deliver care. And so, where's the bottom and how do we manage that? I'm curious to hear how perhaps the panel might respond.
Sure, I'd love your thoughts on that.
Yeah, so I think thank you for having me here today. I'm with Blue Cross and Blue Shield of Texas. I'm Sharon McClure, and I'm actually here at Innovate. I got to personally witness a knee replacement this morning from Dr. Kreutzer, and it was I was very impressed and enjoyed watching that. But bundled payments. And is it going to lead to a race to the bottom? I don't know. I mean, I think it's very hard for plans. I know it's very hard for us to administer bundled payments. So we've been limited in those. We've had some episodes that we've been able to implement, and we've actually done that with Innovate, and it's been very successful. But the rewards have been lagging. So, you'll have a measurement period, a performance period, and then a payment later. We're trying to find ways to drive more competition to where there's more information available to the physicians, and also the rewards are faster. But I mean, I guess there could be a race to the bottom for certain providers. There's still so much variation in the system. And we know that. We've seen that for a long time. Very high hospital cost is compared to much lower ambulatory surgery center cost. And there's even variation among hospitals and among ambulatory surgery centers. So if we can get price competition introduced, even though it could lead to more and more affordable care. Now, I see your point that once you get as efficient as you can, how can you potentially improve upon that? I think we need to look at different measures, maybe comparing not against past performance, but comparing against the market. And there's still just so much opportunity to drive cost savings through site of care initiatives and knowledge and incentive programs that I think that it's just a change of the model if we see that.
Question for both Corin and Zimmer in particular. So as we look, and then of course, Caitlin, I'd like your insight on this, Stefan as well, and Shara. The real costs on that 18-19% GDP is less so the devices and more so the workflow. Over the last 15, 20 years, I think we've had net less physicians in the system and almost a 35 to 40% increase in administrative hiring. And so as we look at risk stratification, I'm backing into this, as we look at risk stratification in the ASCs, and we're starting to see a higher acuity procedure from inpatient to outpatient, especially cardiology, orthopedics, and spine, do the device manufacturers have a responsibility in this? Or is it more about the workflow and risk stratification and the ridiculous EMR, EHR billing complexity that has been introduced over the last 15 to 20 years in the system? So Stefan, that probably cuts to the core for you from both the device side, the robotic side, the paperwork administrative side, and the reimbursement side.
You hit the nail on the head, and that's one of the areas I think where we can really remove some of the fluff and the inefficiencies, because I can only operate so fast and I can only see patients so fast. And the only thing I'm not good at is dictating my op reports, because I hate doing it. And I'm always on the delinquent list at the hospital, not at the surgery center, but at the hospital. And so, and I know Blue Cross Blue Shield is working diligently on this. And there's been a law passed that I think if you have proven yourself on pre-certification that you don't have to get pre-certification. And it's these kind of discussions where we have all the stakeholders that can help us become more efficient when it comes to that burnout activity that we do. And you know, Mike, you know this as well. You know, we don't like paperwork. We hate it. And we don't like doing pre-certification. And so thanks for asking the question. I'd love to see Shara's and Caitlin's input on this, specifically because they really have the ability to make a change there. So maybe we'll start with Shara and then with Caitlin, and then ask the devices what they can contribute.
Yeah, I know that we've seen increases in administrative costs. You know, part of that's to combat fraud. Part of it is to really scrutinize some billing practices that we've seen. And you're right, Dr. Kreuzer, we did see a Texas law passed recently that gold cards certain professionals if they have had their procedures approved 90% of the time. We are implementing that and putting it in effect. You know, it will be reevaluated every 6 months. But some things that we're potentially looking at, you know, as long as you see that variability and differences in same surgery performed in different settings. So, for example, we identified a list of about 1,500 procedures that our clinicians determined could be performed safely in a surgery center 92% of the time. For those 1,500 codes, average cost of a surgery in a hospital is $7,000. Average cost of the surgery in the surgery center is $3,000. So, what can we do to administratively simplify those surgeries performed in the surgery center, but perhaps, you know, try to figure out how you redirect those from the hospital to the surgery center so that there is not only cost savings, but administrative savings as well. So those are things that we're kind of working on designing. You know, I know that this was about administration, but we did implement a program where we increased the professional fee for those 1,500 surgeries up to 50% if they're performed in a surgery center as opposed to the hospital. We're starting to see really good results with certain groups. I think that we have an opportunity to, get the message out and make sure that the proceduralists know that this incentive is available. And not only is it an opportunity, for the surgeons to improve their reimbursement, but it's also an opportunity for their patients to lower their out-of-pocket costs.
Yeah, so I'll build on that. Shara, I haven't had the pleasure to meet you outside this panel, but Blue Cross Blue Shield and Anthem has been one of our best payer partners. We have found you, especially ACSC, to be so incredibly innovative and leaning into things like physician incentive programs and shared savings models. Blues in Florida leaning into shared savings when it comes to supply expenses. And even with our sister United Healthcare, we are very much educating them about ways that they can remove friction from surgeons who are doing high quality, lower cost cases in appropriate settings. So helping them rethink things like pre-authorization for surgeons who are working with SCA and ASCs. So super grateful for how payers are rethinking the space. On the supply side, last stat I saw is that in total, supply budgets equal approximately 25 to 33% of the med-surg operating expenses at U.S. hospitals. For SCA specifically, we actually spend more on supply dollars per case than we do on labor per case. So supplies are one of the biggest drivers of cost within our ASC P&Ls. And so I'm so grateful to see supply partners at this table, Zimmer and Corin, and I have seen a really intentional leaning in from implant manufacturers specifically over the last 2 years, creating differentiated solutions for the ASC space, whether it's different size sterile processing trays, different ways to think through sterile processing based on site space constraints within the ASCs. And I still think there's more we can do in making supplies at least a lower cost than labor on a per case basis.
Caitlin, on that point for both Nitin and Vaughn on the OEM supplier side, Stefan, you know the number. You and I were chatting about this. As we have this decentralization and call points from the hospitals to now the ASCs becoming more fragmented or decentralized, the cost per call for a sales rep is going to change dramatically. And I believe, Stefan, you had the number for me. It was something like 20 to 25% of the actual cost of an implant was derived from getting the rep to the facility?
Yeah, that's local sales and distribution, and Nitin and Vaughn, you can maybe clarify if that's true, but it's my understanding it's 20 to 25% is local sales and distribution. And so if you as a device company were to drop off the implants and the instruments directly at the surgery center, and maybe not a completely repless model, but a rep-light model, that could be significant cost savings to you that can then be shared or passed on to the facility. And I just want to confirm that that is correct.
And as we confirm that, where I'm going with this, with both the device manufacturers, is your model's been set up until recently to sell to major hospitals, not as much to the rapidly expanding ambulatory surgical centers. So you having to reimagine an entire Salesforce construct is interesting and fascinating from the outside. How are you wrestling with this inside Corin, inside Zimmer?
Vaughn, you want to take the first swing here?
Yeah, thanks, Nitin. And yeah, born Bonnie, President Corin USA, and you can probably tell by my accent, I'm not local, so formerly from Sydney, Australia. So delighted to be here, and thank you to Mike and Stefan for including Corin. I guess, Stefan, to respond to your question, directionally, that percentage or that cost to serve is correct. It does vary from market to market. And if I may comment on the introduction or usage of our technologies or technologies in general within orthopedics, and maybe I'll let Nitin comment on the as I'm rapidly educating myself on the payer healthcare dynamics in the United States. So, I mean, from a technology perspective, an access perspective in the ASC, we see huge potential in our ability to be flexible and provide specific ASC type arrangements as it relates to the acquisition and access to our technologies and our implants. The benefit of being a private equity owned smaller organization is that we can remain flexible in that space. So I think there's been a lot of comments around value-based care and true partnership. I think we're well placed to do that, and orthopedic companies generally have a desire to do that. I would say, in my experience, having worked for smaller and larger organisations. Nitin, maybe I'll pass to you for comment.
Sure. Lots to say. We started out the question with talking a little bit about incentive payments. I heard Shara had mentioned the incentive payments, and Caitlin, you didn't call it out, but I think the SCA has, or Optum with SCA has a similar incentive payment, the QPIP program, to surgeons moving their procedures to approved facilities and allowing for 50% bonus on the professional fee within the fully insured population at UHC. So really fantastic incentive alignment with the physician, the facility, and the payer for movement of high cost cases when appropriate to outpatient facilities. This question, I think, started, Joe, with the question about whether device companies should have a role in creating these efficiencies for the provider, and then it kind of moved on to the ASC model. And I wanted to comment on Stefan's number that is directionally accurate. Our cost of sales in local markets can be around 20%, and that's the cost of freight, cost of delivery. I mean, we're doing so much. Our cost of supply has gone up. So imagine all the supply chain issues worldwide, whether it be getting titanium from Russia, which is now not possible, and getting it from other sources, including China and locally in the United States. Our cost of supply has gone up significantly, and then making sure that our products are available at where a physician might be operating at 3 different ASCs instead of one hospital. And then having it at the appropriate time in that ASC, because most of the instrumentation needs to arrive at least 24 hours in advance. So it's increased our E&O costs by having to have higher volume of instrumentation at more facilities with more sales rep assistants. And actually, post-COVID, with most of the facilities being kind of down hospital staff, a lot of our sales reps aren't really doing the sales rep job. They're doing the hospital employee job, which is they're helping the surgeons as a circulator, getting the right equipment in the room. And oftentimes, I think Dr. Kreuzer's facility is probably a unique one in many cases, because he's got Edgar and Jan and experienced circulators and assistants, and many folks don't have that because there's been such a drain on staff. And so I think that it is costly for us to do that, but I think in many situations, physicians and ASCs don't want to remove that person from the room. So, but I do think, I want to just tie back one comment. I do think device companies have a strong opportunity to create efficiencies with and for the provider. And some of that's not even in the operating room. I mean, the example would be, if Dr. Kreutzer, Dr. asked myself, like, if I could see patients that mostly need surgery versus patients that just have hip pain or knee pain, that's a big difference, right? And so by creating technologies, I know the buzzword of the day is AI, but we're working on specific technologies to kind of pre-certify that patients are needing certain procedures. Well, that's great. If I can send Stefan only the patients that need a hip or knee replacement, that's created a massive efficiency for his own practice. So right. So there's huge opportunities for us to collaborate further. And I do think that PE will further actually improve the ASC efficiency, because that's, if there's one value that PE is bringing, is investment in technologies and efficiencies, right? And there may be administrative costs associated with that, but they're trying to drive efficiency. And Innovate's done it on their own, but many practices don't have the opportunity, skill set, or capital to make those investments on their own. So hopefully I answered a variety of the questions there. Thanks for the question, Joe.
Yeah, and on that, so we see organizations like Stryker getting involved more and more in the ecosystem around ASCs and even hospitals outside of a pure device play. They're purchasing multi-billion-dollar acquisitions of communication companies. They're also starting to get involved in machine learning, advanced analytics, and patient stratification on risk and data. Prep, surgery, recovery plan, compliance, post-surgery, which all go into that 19% GDP. Do you not being a spokesperson for Zimmer, and the same with Corin, but especially for Zimmer, do you see the model of med tech companies going beyond the device itself and getting insinuated into reducing those costs, increasing efficiencies, thereby increasing your ability to sell more implants devices into the ASCs?
I mean, Joe, the quick answer is 190%, right? We can't sell we're not trying to sell a product, we're trying to sell a solution. I don't want to give you a place to get a hamburger. I want to give you a Happy Meal and a place to sit down and a place for your child to play. Right. And so and we fully are aligned on that. The example is we had a recent acquisition just in the last year of a efficiency technology for the operating room. So starting to track efficiency, starting to help providers who may not be as scaled up in understanding efficiencies get the data so that they can create efficient operating room environments. And so, we've already released the first predictive algorithm in orthopedics with an AI algorithm called Walk AI, which basically identifies patients at risk at the 2-week time frame for poor outcome at 90 days. And so we're basically we're trying to objectify the episode of care, ultimately leading our providers to give more quality. And I think that's one thing that we're not talking about too much here, which is, there is going to be a shift towards higher quality. And so as you see the consolidation, you're going to see a push towards employers, insurers trying to measure that quality and honestly shift patients towards the highest quality, lowest cost sites of care. And so ultimately, that's what we believe at Zimmer Biomet that we can offer by enabling our providers to track, measure, understand, and ultimately perform at the highest level.
So I'd like to pose a question, Joe. I hope you don't mind.
Of course.
We had a wonderful talk on private equity taking over orthopedics. There are 3 stakeholders here. One runs facilities, one is a payer, and 2 devices. They all have significant capital, and they have skill sets. SCA has a skill set of doing claims management and revenue cycle management, which is the bane of my existence. Shara has the capabilities of making me more efficient by not making me pre-cert. Nitin can help me improve my efficiency for my patient to have him come in at 2 weeks for manipulation under anesthesia because he's not doing well. And Vaughn has robotic technology and has preoperative 3D planning software that makes me extremely predictable in the operating room. Why don't we put these 4 people into a private equity firm and they fund us instead of the private equity? Because they have technology that can make me better, and they have an incentive to make me better, and they get them, instead of 20% of what private equity gets, they get 10%. Why isn't this the future model?
Great question, Stefan. Love to hear our panel chime in. Vaughn, you want to start us off?
Oh, go ahead.
No, go ahead.
Yeah. I mean, that's an interesting question, Stefan, and certainly not without its complexities. And I think there probably lay the answer to your question is that it is highly complex. Not to say it should not be done, but it is highly complex with significant competing objectives. But would be my answer.
Yeah, and I agree, Vaughn. I think some of the complexity with the private equity model is just one, the period with which they want to hold the investment. Are they willing to make investments today that they think they can get a turn on, when they want to recap in 4 to 5 years? Which is why we say at SCA and at Optum, we wed for life. And the good part about that is we're going to make those investments today, and we're okay having a headwind, whether it's a de novo or coming up with just differential plans to support physicians' independence. We're okay with doing that because we don't have a term period with which we need to monetize that investment. And then I think the last piece is what Vaughn just said. It is incredibly complex. And so for a private equity company to have the depth and all those different expertises that you just referenced, Dr. Kreutzer, I think it's a rarity. And again, I think it goes to investment around creating a leadership team who can really think through all those different components.
Kara?
I think I like your idea on certainly the components of collaboration, bringing stakeholders together to try to solve problems together. We absolutely need to do that. We have invested in certain firms that are in the provider space. Historically, just speaking as a payer, and I know that we're a payer that's a little more on the traditional side, we really haven't integrated so much into the provider space. I think I heard you say we have capital and we have skill sets, and so we've tried to focus on our skill sets. And when I look at where we compete for price against other payers, we compete in the employer space, and so that's kind of where I've seen most of our investments, whether it's improving the member experience, improving the employer experience, creating platforms where other third-party vendors can be integrated. We've invested in certain third-party administrators, but I think it's an interesting idea, and definitely support more collaboration on how to solve for administrative hassle, how to solve for lowering costs, and how to solve for improving quality.
Question relative to Stefan's inquiry is, we're watching hospitals suffer badly about having talent on their team. We're watching nurses leave a hospital and come back as travel nurses and getting a 30 to 50% increase and showing up the next day just with a 1099 instead of a W-2. And I love this push, this massive push to ASCs. Now, I want each of you, from your respective areas of concern, how are we going to find talent for these expanding ASCs? And if you've ever dealt with PE before, and this is a blunt force trauma statement, PE notoriously are really bad in leadership and retention in their companies. So I'm just curious if any of you, since your business model is, contingent on ASCs being successful, the manpower, because nobody addresses that, the manpower side and private equity's inability to manage and retain talent in nearly all of their organizations. So I would throw that first, and let me pull you back in and what Zimmer thinks about on that, because we're romantically falling in love with Christmas morning, but Dad's got to put all the toys together around the tree, and it's not going to be that easy.
Yeah, I mean, I think first, this is a global problem. This is not just, southeastern United States or regions within the U.S. I mean, I've seen this in France, I've seen this in Spain, I've seen this in Australia. I mean, this is all over the place, where surgeons, hospital staff, systems are talking about the movement of their staff outside of the hospital. A lot of retiring, a lot of changing careers, and so this is a global problem that is. I mean, probably we could spend a whole conference on this. I do think, though, that one comment I'll make, though, is I've seen less of this in the ASC environment, mostly because it seems like staff, and Dr. Kreutzer referenced this comment with his own staff, is really happy, right? They're partnered together. They can see the immediate outcome. They have that feeling of ownership to the ultimate goal, whereas in a large hospital system, there's this disconnect, right? They're scheduled by someone 3 floors above them. They have to be on call. They have to do this and that. And all the things that drain an employee are present in a hospital, where they don't necessarily see some of that in the ASC. That being said, ASCs are still going to have some of that problem because staff is an issue. I will say that you referenced the PE firms and their inability to manage employees maybe at the best in the best way. I think that's going to separate the good ones from the great ones, right? I mean, that's when you see the ones that really grow fast and really are able to take on more practices, more groups, and you have a high satisfaction. And orthopedists are only going to join groups where other orthopedists are super happy, right? That's the biggest first thing you do when you figure out what PE firm you're going to join is you call the other orthopedic surgeons and you say, how's it going for you? How have you been able to grow? And so I think that's going to really create the separation. I don't know if other folks have other comments that might relate.
Yeah, no, I'm happy to jump in. So across SCA Health, we employ about 9,000 clinical teammates in the field. So very much, Joe, those pains that you talked about are something that we have been spending a lot of time thinking about. certainly, I agree with Nitin and his comments around why nurses and other clinicians, scrubs, prefer to work in an ASC compared to a hospital, but that doesn't solve the talent wars. And so at SCA, we have been incredibly intentional about building out training programs. We can't expect just to hire an experienced OR nurse with 10 years OR experience. So we've created Peri-Op 101 courses that train nurses for success in the OR. We've built our own preceptorship model. We've also created nursing career ladders that rewards nurses for expanding their leadership capabilities and then their skill set capabilities. And as they move up the ladder, they can obviously make more money for them and their families. So long-winded way to say, completely agree, Joe, on the challenges in the industry, and we're gonna have to solve it ourselves. And so that's why we're so passionate about just pouring into the learning and development of our critical and so important and so vital clinical resources.
Thanks. Stefan, I want to be respectful of the time here. We're at 11:26. Do we have another minute or two to finish this up?
Yeah, absolutely. If you can wrap it up, sort of give your thoughts, and then maybe give each the member of the panel a to-do list. And I'm hoping that this will be a platform for bigger discussion, because it's been very refreshing, the honesty and the straightforwardness of all the panels. It's been great.
Yeah, what I'd like to do is go around the panel, and if you had one, and I'm gonna ask you to be very specific. If you had one wish that could be executed on in the next 30 days that you think would impact quality of care and the management of this runaway costs, what would it be? And so, Cheryl, let's start with you. One wish, and and let's be as specific as possible.
So my one wish would be for physicians and patients to just consider price in their decision making, just like we consider price in every other purchasing decision we make, whether it's buying a house, buying a car, buying a meal. Many people, they don't always choose the lowest cost item, but they consider price in their decision making. So my wish would be that those making healthcare decisions, whether they're for themselves or those who are influencing them through referrals, just consider price. Hopefully we will start making that easier with transparency tools and with making sense of transparency tools, but just consider price and decision making would be my one wish.
Thank you. Vaughn?
Yeah, thanks, Joe. I would say for us as a smaller challenger company with a fantastic technology product range, as Stefan outlines, would be market access to provide an easier pathway for our customers to access our products.
Caitlin?
Sure. 30 days is a short time period, but my wish would be for physicians to really recognize that the power they have. No one has more trust in healthcare than physicians, and frankly, I don't think anyone ever will. And the healthcare system very much needs you to lead, and no one is going to fix it for you. So my wish would be that physicians could really embrace partnership and working with each other at the next level, and so that they can speak with one voice. And I think when they're able to do that, they'll be able to realize outsized influence.
Nitin?
Well, my colleagues said some great comments there. Shara referenced cost and incorporating cost. I'm going to go maybe the similar direction, which is just to focus on quality and how quality is going to become continually. It is important now, and it's going to become more important as we drive down cost, and a focus on the consolidation, but a focus on quality and tracking those outcomes, understanding what leads to better outcomes, and using the technologies available to drive better outcomes.
And Stefan, since it's your host, would you finish up with what your wish would be?
Yeah, when my office manager took her job, one thing she did is she sat with every person in the office. That's the front office person, the surgery scheduler. She spent a day with me in the operating room. She spent a day on the phones. So she learned everybody's job. And that, I think, makes her such a wonderful leader because she can do all of their jobs. Having Shara in the operating room with me today, I mean, I was extremely excited because it's so important for you to know what I do, because it's not about CPT and ICD-9 codes, it's about patient care. And it is about robotics or not a robot. So if we can have more cross-pollination where the people that can make change happen spend time with the other person. Joe, you were in the operating room with me. Nitin is a surgeon. Vaughn spends a lot of time in the operating room. Well, maybe Vaughn should spend a day with Shara to see what her challenges are. And so then we become more tolerant of each other's challenges. And I think we'll be more likely to come up with solutions. So, Caitlin, I invite you, next time you're in Houston, spend an hour with me in the operating room, observe a surgery, which I'm sure you've been in many operating rooms. And I think that cross-pollination and being more tolerant of each other and what challenges we have may make us a little bit more open to suggestions of changing the game. And I think this has just been a great panel discussion, a great open discussion on hopefully making some change. So thanks, Joe. You've done a great job, as you always do. And thanks for having us.
Yeah, my pleasure and privilege to be able to help moderate this for sure. Mike, I'll hand it back to you, and thank you all for your contribution, your transparency, and your lateral thinking, which is what it's going to take to probably fix this mess we're in. So, Mike?
Thanks so much, Joe. Not surprisingly, a wonderful job moderating. And thank you to our entire panel, a few of whom we'll see back in a little while. But really, just an absolute privilege to have that group of people here with us today.